Welcome back. In this video, you are going to learn about cystic fibrosis, which is a very important topic in pediatrics. You'll get plenty of questions in MCQs, competitive exams, or even for theory. It is very important topic for undergraduates. So write down the note. Make a good note so that you can revise the same thing during your final exams. Cystic fibrosis. I tried to collect good amount of information and made it like a crisp notes. I think this will be sufficient for you people for your theory exams, even for competitive exams, I hope. Okay, let's crack the shell so that we'll get the good information. So first thing, in pedia, not in pedia, when you come to medicine sector, if you see a disease, first you should know whether it is some inherited disease or not like acquired disease, so that you can comment on the which type of transmission will be there, or whether it is inherited or acquired, so that it becomes easy to remember. So this is a autosomal recessive. AR means autosomal recessive trait. Okay, so if there is a trait, if it is inherited, there must be some gene involved in it, so we call it as a CFTR gene. So full form, cystic fibrosis transmembrane conductance. Write notes parallelly with me so that later you won't miss out anything. Conductance, right? So what is the use of this gene? This gene regulates gene present on which chromosome? Yeah, it's very difficult to remember chromosomes. Even I feel very difficult. That's like a clingy things, but day by day if you read again and again, you will remember well. Okay, it's a 7q 31.2, right? It's a chromosome number. Yeah, it's very difficult, but still you have to crack it, right? Then gene codes for protein. It's a CFTR protein. Okay, then CFTR protein, what a more detail like extra edge is like it is of 1480 amino acids. It includes protein amino acids, something, right? Yeah, then next point, CFTR protein regulates chloride and bicarbonate across the epithelium. So whenever you hear name like cystic fibrosis something, then first thing you have to remember is it is related something to the chloride and bicarbonate. Okay, this is the main point you have to remember. Something, if you want to remember like cystic fibrosis, then you have to remember chlorine and this bicarbonate ions. The disease runs around this only. Like you will come to know more about this in clinical feature, why I am stressing on this point. Okay, then what is the most common mutation? It's deletion of phenylalanine. At which location? Guess. It's around 500, right? 508 position. 508. So other than this, any other mutation? That is the most common. Then next to that we have G551D mutation. Here it replaces glycine, will be replaced to aspartic acid. at 551 location. So G remember, G glycine. Okay, fine. So we have classes of mutation. Let's make it bigger so that you can see well. Then we have class of mutation. Oh yeah, we talked about it now. Class 1, class 2, then we have class 3. Class 1 is related to some defect protein synthesis, like completely absence of CFTR protein. Make it short, like you can remember well. You can fill the paper if you know the content, right? Absence of CFTR protein. In second one, misfolding happens. Misfolding of everything runs around CFTR gene. Okay, CFTR protein, and there will be trafficking defect. So most common gene defect, yeah, that's right, 508 mutation. This is one example. Okay, there are many mutations happening in cystic fibrosis. This is the most common. Then we have CFTR protein is not stimulated by CAMP or ATP. Basically, it's a non-functional CFTR protein present on the apical surface, like the second most common, G551D mutation. Yeah, you need to remember, like there is something absence of CFTR protein in class 1. Then in second class we have F508 mutation. Then the third one runs around the G551D mutation, right? Okay, then main important, pathogenesis. So we have like pathogenesis varies on the different site where these sodium and bicarbonate receptors are present. So we will crack into a small briefly so that you will remember everything. So it depends on the specific site or specific organ. So let's take a very important gland, sweat gland, where sodium and chloride runs around the names. So this is a sweat gland. Normal function is to reabsorb chloride ion. Right? Then tracts. It may be about GIT or even respiratory tracts. We'll make it a respiratory tract or genitourinary tract. These are the main like tracts where these receptors are present, right? So usually what happens, like take this as a normal cell. Normal, we have chloride channel, then we have sodium channel. Usually what happens, chloride goes out, then sodium comes in, right? But what happens in this cystic fibrosis, listen carefully, listen. This is chloride and this is sodium channel. What happens here is like chloride channel is not working. We'll take in the different color. So this is your chloride channel which is not working. What happens, sodium comes inside. What happens, so what it results is like usually normal function of CFTR protein is to secrete chloride ion, but here what happens, chloride combines with sodium and mucus. Remains what happens if chloride is defected, then it becomes watery, right? Yeah. Okay, this is the cystic fibrosis one. So what at last what happens in cystic fibrosis? There is decreased, right? Decreased or increased? It's decreased. Good. Increase movement of sodium from mucus to cell. So what happens then? Mucus becomes thick. Obviously, if something is more, then it becomes thick, right? Then dehydrated, causing obstruction. It becomes so thick that secretions become so thick that it starts to obstruct. Okay, this is your pathogenesis. Now the entire pathogenesis, the amount of quantity required for the answer and the basics, that much I try to concise. Okay, we'll revise it so that you won't confuse at last. Then we'll go to clinical features. This is for that was above thing was for pathology, and this is like for pediatric section. So mainly we have to look into systems wise. Respiratory system. What happens? Pansinusitis, infection of sinuses, then increased nasal polyp incidence. Nasal polyp, if you want to know more about this nasal polyp, you can refer my ENT section video, nasal polyp. We explained it very detailedly there. Incidence will be increased. There is a mechanism for that, why polyp incidence is more. In that video we explained, you can check on that. Then we will notice like earliest lesion in lungs. It's bronchiolitis, where it leads to bronchiectasis, right? Okay, so mainly it affects upper lobe, then the middle or lower lobe. Not upper limb, it's upper lobe. Then if there is some infection running around, we should have some organisms, right? So what are the causative organisms? In children's, the big father, Staphyl aureus. Then in adults, Pseudomonas. How it looks? It's like on culture we look it like a green color due to its that property. It secretes pigmentation on culture. Okay, Pseudomonas aeruginosa. Then, so how you are going to treat it? We'll discuss this treatment part here itself. So how you are going to treat it? If you want to give patient oral route, then prefer ciprofloxacin or azithro. Ciproflox belongs to which class of drug? Guess it fast. Chloroquines, right? Check out that video in pharmac section. We explained it very detailedly. Then we have nebulization, where we give levoflox, even that belongs to chloroquine, or amikacin, Tobra, Astrionam. Comment me about this drug. It is the only drug in that class, or like we'll say class. Which class? Comment me in the comment section, right? I'll see who will comment first. Then what else we'll see? It also increases incidence of Burkholderia. or even aspergillosis. Which kind of allergic? Okay. Then this was all about like respiratory. Then coming to we said like even GIT section, we'll see the symptoms from GIT. In neonates, it causes meconium plug syndrome. What is meconium? Yeah guys, what is meconium? It is the first stool passed by the neonate, right? Yeah, don't get confused about these terminologies. Meconium ileus. So how you'll manage? If meconium is not coming or something is happening, then we have to take it out, right? So we give gastrographin enema. So there is something called topic, I don't know you people know or not. There is something called diagnostic. We call it as a diagnostic and therapeutic. Listen carefully. We call diagnostic when we just use that for diagnosing some condition like investigations. Therapeutic is like it includes both diagnostic plus treatment, right? Diagnostic plus treatment, where diagnostic is nothing but an investigation. Then like undergoing that procedure, that patient will be treated from that condition. So we call it as a therapeutic. I hope that is clear, right? This is basics. So this gastrographin enema it acts like a therapeutic, not only diagnostic. Okay, so it treats the disease, like not disease, the symptom which baby is facing. Then we have in childhood, this may cause distal intestinal obstruction syndrome. So what is the most common symptom you will see is constipation. Something is obstructing, so then constipation, bahar nahi aa raha hai, frustration happens, right? Yeah, it happens. Then you'll see this the condition in board exams of medicals, like you would have faced already. Then in liver it causes biliary cirrhosis. Then we have in pancreas, this is usually like symptoms will be seen wherever this chloride and bicarbonate is linked. So you have to know wherever they are present. You can check out that thing in my physiology video, where are these receptors and all present, so that it will help you in detail. So in pancreas what happens? Exocrine pancreatic insufficiency. Sufficiency. So what is the point of knowing these 2 points is like it causes fat malabsorption. Okay, yeah. Then what happens? Coming to genitourinary tract, just remember azoospermia. Tell me what is meaning of this azoospermia in comment section. We'll study this on our OBG section, infertility chapter. Okay, comment me those who knows answers. Then at last, coming to the starting point, sweat glands. So there is a loss of sodium and chloride loss in sweat, which leads to sodium is losing, so hyponatremia, mic. Then chloride is losing, hypochloremic, metabolic alkalosis, right? Hope you won't forget this point, right? It's all in the name. सब कुछ नाम में ही रखा है. Then we have screening. So if something is happening, then we have to screen it, we have to treat it, right? So we'll go for a screening. We do it by, yeah, anyone? Screening will be done by serum immunoreactive trypsinogen, short form IRT. So we have a diagnostic criteria for cystic fibrosis. So let's make it let's note it. Diagnostic criteria. So we have to say that it is a cystic fibrosis, then it has to like fall under this diagnostic criteria. So what is that? Presence of typical clinical features we discussed above, which may involve any system like respiratory system, even GIT, or even genitourinary tract system. Or this or is important, okay? History of cystic fibrosis in sibling. Since it is autosomal recessive, so if any family history is present, then we have to consider it. Or positive newborn screening test with, not or, with a 2 elevated sweat chloride concentration more than 60 millimole per liter on 2 separate days. Okay, let's write or downside. Or condition B may be more than or equal to 2 CFTR mutation present. I said na, class 1, class 2, class 3, or even there are 10,000 mutations, around 10,000. So we need to remember, we can't remember everything, right? So we used to remember like most common, the second most common. Take that, if the two genes we discussed about it, if those two are present or more than that present, mutation present. Or then point C, abnormal nasal potential difference measurement. Now you have to remember this diagnostic criteria because there is no trips and tips, like it's a fact. Okay, then treatment. You diagnosed, you said patient you have a rare disease or some complicated disease, then okay doctor साहब क्या करेंगे अब? Being a doctor, you need to treat, right? So to treat, you need to know the topic well. If you know the topic well, so that you can find the solution. And now we are discussing the solution. So first, CFTR potentiator. So there is something which is not working, you need to make it work, right? So this potentiator acts like that, acts on that, like it keep the gate of CFTR channel open. So there is a drug called as, very important, like just don't forget it. These all drugs, like you can remember, like Caftor. Not, this is not the mnemonic, these people ends with the Caftor. This is Ivacaftor, okay. Then second we have CFTR corrector. This is most commonly used in that I said, like most common gene mutation. Right? Okay, so anyone know which drug we are getting under this topic? Yeah. If you all like used most commonly caftor तो रहेगा, we need to add something in front of that, right? It's a loma caftor, tiza caftor, or alexa, right? So if we make a diagram, it will be easy to remember, right? This is a cell, then you take this as a CFTR protein, these are your Golgi apparatus. So this first one acts on the path, then second one acts here. Okay, that was a like bunch of a knowledge, like we'll revise it quickly. Okay, today we discussed, in this video we discussed about cystic fibrosis, important topic, very important. It is a autosomal recessive trait, right? Recessive trait, CFTR gene, full form no need to remember. If you want you can remember, which regulates this chromosome 7 Q31.2. then gene codes for this protein is CFTR protein, नाम में रखा है. It is of extra, it's like 1480 amino acids. Then we have CFTR protein regulates chloride and bicarbonate across the epithelium. So most common mutation is like F508 deletion. Then second most common is like 551D mutation, where glycine will be replaced by aspartic acid. Okay, we have classes we discussed in detail: class 1, class 2, class 3. Class 1 is absent, class 2 is related to F508, class 3 is related to G5518D, right? Then we discussed about specific pathogenesis related to sweat glands, then various tracts like the respiratory tract, GI tract, then genitourinary tract. Okay, so basically here mucus becomes thick so that it obstructs the regular routine. Okay, then coming to clinical features, respiratory symptoms: sinusitis, nasal polyp, bronchiolitis will be converted to bronchiectasis later. Then we have most commonly it will be affected to upper lobe. Causative organisms: staph, then pseudomonas. Treatment we discussed in detail. Then coming to GIT, we see in neonates meconium plug syndrome, then meconium ileus. We will treat it's like therapeutic treatment, gastrographin enema. Then in childhood we see distal intestinal obstruction syndrome, where most common is constipation. Yeah, medicos, you remember me, right? Yeah, liver we see biliary cirrhosis. In pancreas we see exocrine pancreatic insufficiency. Why we learnt about this is fat malabsorption. Then genitourinary, that azoospermia, don't forget to comment what is the meaning of the azoospermia. Then we have sweat glands related to sodium and chloride loss. Then we did screening test, serum immunoreactive trypsinogen. Then we did the diagnostic criteria. Take a snapshot of this portion, and if you are like preparing for exams, take a snapshot of this one and take a printout and paste around your routine places where you roam around, so that you can read again and again. You will remember, mainly remember this newborn screening test. 2 elevated sweat chloride concentration above 60, this is important, on 2 separate days. CFTR more than 2 CFTR mutations, and even nasal potential difference moment measurements, right? So we even diagnosed it. Then we came to treatment. We came to know that these are caftors: Eva caftor, Luma, Teza, Alexa. Yeah, I hope you people enjoyed the video. Subscribe to the channel for more videos. Hope you enjoyed it. Bear with my lame jokes, okay? Don't take it too personally, okay? Don't forget to answer that azoospermia and another question I asked in the comment section. Thank you.